Discussing bowel symptoms contribute to hesitancy around broaching the subject with a healthcare provider, but GI issues affect more than 40% of Americans each day. Gastroenterology, it's a gut feeling. Tonight, on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, where we provide health information based on science and built on trust. I'm your host, Dr. Andrew Ellsworth, and this evening we will delve into the field of gastroenterology while addressing questions from our viewers. Gastroenterology is a branch of medicine dedicated to the study of the digestive system, which encompasses the esophagus, the stomach, the intestines, the liver, pancreas, and gallbladder. If you're experiencing symptoms like abdominal pain, bloating, irritable bowel syndrome, Crohn's disease, or ulcers, your primary care physician may refer you to a gastroenterologist. These specialists focus on diagnosing and treating various digestive disorders. The field of gastroenterology is ever evolving, with ongoing research leading to new treatments, diagnostic methods, and therapies aimed at enhancing patient outcomes. Tonight, we'll explore common gastrointestinal or GI issues and respond to your questions. Thank you for being part of our discussion. This evening, we are joined in the studio by Dr. Cristina Hill Jensen from Avera Medical Group Gastroenterology and Dr. Becker Abdu from Sanford Center for Digestive Health, both from Sioux Falls. Welcome and thank you so much for joining us here this evening.
Yeah.
Dr. Cristina Hill Jensen, you are not new to this show.
No.
You've been on several times. Welcome back. Thanks for being with us.
Thank you for having me.
Could you just share a little bit about yourself?
Sure. I actually grew up on a farm outside of Brookings and went to undergrad at University of South Dakota and did my medical school at University of South Dakota. I did my internal medicine training at Tulane University in New Orleans, Louisiana. Started my GI fellowship there, which was interrupted by Hurricane Katrina. So finished my training at the University of Iowa. And since that time, I've been back at Sioux Falls with Avera.
Awesome. And you've been with Avera now for
18 years this summer.
Awesome.
Yeah.
Tell us a little bit about your practice.
I see general gastroenterology, and I have a focus on inflammatory bowel disease. I see a lot of patients with celiac disease and with motility disorders as well.
Wonderful. Well, I'm sure we'll have some of those questions here for sure. And Dr. Becker Abdu, welcome, and tell us a little bit about yourself.
And thanks for having me. So I am originally from Edmonton, Alberta, Canada. Lived most of my life there. I did my undergrad in Michigan, ended up going to medical school at Saba University, and then came back to Michigan for my internal medicine and my fellowship. And I recently graduated about a year and a half ago and moved here to South Dakota.
What do you think?
I like it. I really like it.
What was the draw?
What was the draw?
Yeah.
So it was a little bit closer to home, where at the same time it was a great city, it was a great offer, kind of wasn't as busy as some of the metropolitan areas, so I can get to work and go home, but at the same time still be very busy. So it was kind of the best of both worlds for me.
Great. And tell us a little bit about your practice.
So I'm also in general GI. I see pretty much everything. I do have a little bit of bias towards motility.
What does that mean?
Meaning, for the most part, people that suffer from either swallowing disorders or constipation, where we test the muscle function on how things move in the GI tract. So different tests where not every gastroenterologist does them.
Sure. Awesome. Well, we'll dive into all those things more. Before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about gastroenterology. Viewers can contact us three ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it is not required to submit a question. The viewer will be drawn and announced at the end of this program. So we just got done with March, and I understand that's a special month. Tell us about that.
Yes, it's Colon Cancer Awareness Month, and so it's a very important thing, especially lately in the past few years. Our guidelines have changed. I don't think everyone knows that. It is now age 45, not 50, 45, so very important. We are seeing cancers in younger individuals. There's been a really sharp uptick, so it's important to get that colon cancer screening at a much younger age, at 45 instead of 50. And that's for the general population, provided that there's not a first-degree family member with colon cancer. Then we would start age 40 or 10 years earlier when that individual was diagnosed with colon cancer.
What are some of the benefits of colon cancer screening? How does that help?
Well, with a colonoscopy, we are going in, we're finding a polyp, and we're removing that polyp, which is a precancerous growth. So we're actually preventing colon cancer from occurring, versus a Cologuard, which is another type of screening test, a fecal immunochemical type test, DNA test, where we're trying to find polyps, but it's not always as equivalent. We're still saying that a colon cancer screening, colonoscopy, is still the test of choice.
And then you can take care of it right then
Absolutely.
and there.
Mm-hmm.
And obviously for screening, that's when someone's not having symptoms, not having any issues, it's just straight up. Because we've seen, like I said, increasing rates of colon cancer, even in younger people. Why do you think that is, Doctor?
So that's the million-dollar question, really. It's nonetheless that we do see it. It's very real. There's an increase in a few percent of younger patients. We call it early onset colon cancer, right? There's some factors that are involved, like dietary factors, obesity, tobacco use, alcohol use. These are the known risk factors for developing colon cancer, and we think these are playing a big part. And so we are definitely seeing them, and so that's why we try to catch it early.
Yeah, I've heard of that certain processed foods can increase our risk, and it must be something in the American diet, because I know in the U.S. we have higher rates.
Yeah.
There's also a blood test to help screen for colon cancer. Can you talk a little bit about that?
It's not commonly used as a spectrum, I think 7 or 9, so not something I have ever ordered or needed to order. So although people sometimes are fearful of a colonoscopy, a stool test is the next best, and very rarely, in rare situations, you can order a blood test for that, but not something that we are commonly ordering or one that I have ordered in practice.
Yeah, I think the detection rate is pretty low yet. They're going to keep working at it, but the gold standard is still colonoscopy. Seems like the prep has improved. I think people complain less about the prep than they used to. What are some improvements we've made in the prep through the years?
I think one of the best things we've done is we've done a split dose bowel prep, where now you don't have to take the full jug, the 4 liters, the big gallon right on the night before, all at one shot. Now we do half at night and then half in the morning, which kind of eases a lot of things. And we are pretty good at kind of guiding patients as to what to expect, little tips and tricks that they can do, like put it in the fridge, mix it with their favorite drink if they need to. And now there's even smaller volume preps. And even more commonly now there's certain pills that you can take with some water to help you prep. And so I think patients more and more are becoming more comfortable taking these bowel preps.
Absolutely. Well, we've got a whole bunch of good questions coming in already, and this kind of follows along the same lines. This is from Facebook. I'm a 50-year-old man. I've noticed some blood in my stool the past week. When should I be concerned about it? Cristina?
Now.
Yeah.
And the answer is now. So blood in the stool is not a normal thing. Talk to your primary care physician about this situation. Get scheduled for examination, a colonoscopy. You're age 50. It's older than that guideline of age 45, so I would be concerned now.
What are some of the things that could be going on?
Well, on a very kind of low risk thing, could there be a hemorrhoid? So a dilated blood vessel down below that's getting irritated. Could there be some type of infection or inflammation going on? Is there diverticulosis? These little pockets that can become weak and bleed. But we would worry, is there a mass or something worrisome there that is bleeding?
Yeah, more than once I've had patients keep telling me about their hemorrhoids until we looked into it, and that's wasn't actually a hemorrhoid. And so it's important to get that evaluated, because you just never know sometimes. You know, some of the times you have that situation where a patient maybe is up to date on their colon cancer screening but has some bloody stools. What do you do in those situations?
So we definitely take a look at their endoscopic record. I mean, when they had their last colonoscopy, if they ever had an endoscopy. That will help, and how soon it was, kind of thing. If you had a colonoscopy 2 months ago and you're having some bleeding, less concerned for a new onset colon cancer. But if it was 5 years ago or 7 years ago and you weren't due for another 10 years, maybe that's something to kind of take a look into. But kind of the same things, you know, I would be considering all those different aspects. Are there hemorrhoids? Are there diverticulosis, inflammation? And of course, I would be considering colon cancer.
Yeah, because things, when we give the recommendation for 10 years or 5 years, that's, you know, based on averages, but sometimes these things can grow more quickly, can't they?
Yeah, oh yeah, definitely.
Someone asked about the new prebiotic sodas on the market. Are these good for my gut health, or should I avoid them? My teenager likes them.
This seems to be a hot topic. I think a certain brand was mentioned earlier. No, I don't think we really need a soda. We don't need prebiotics. If we are eating a very balanced diet, eating all those wonderful greens and wonderful fruits and vegetables, we probably don't need any of this. So I think they've done a really great job with marketing. It makes it very attractive to younger people. But I think soda and nutrition, I don't know how well those two words mix. Even if you throw probiotic or prebiotic in it, I would be less inclined to say, hey, let's drink this. I would say probably don't need that.
Yeah, you know, and here's the key word too. They said prebiotic, which then our body's doing the work and using our normal gut bacteria. But talk a little bit about that, because probiotics are shown some benefits. And what is a probiotic?
So a probiotic, kind of like the bacteria that can help with, you know, in the GI tract. There's many different bacteria in the GI tract. So there's probiotics that will kind of help stimulate good bacteria that we know of, kind of thing. And so that's basically the probiotics.
Yeah, excellent. This email question says, can you explain the difference between IBS and IBD?
So irritable bowel syndrome, IBS, it is a syndrome with change in bowel pattern associated with abdominal pain that typically is relieved after a bowel movement. It can go from one end of the spectrum with constipation, having fewer than 3 bowel movements per week, to diarrhea, more than 3 bowel movements per day. So urgency or not going for weeks on end. Inflammatory bowel disease encompasses 2 diseases, Crohn's disease and ulcerative colitis, which causes chronic inflammatory changes of the GI tract, usually causing bloody diarrhea and abdominal pain. So a big difference in what they come from and how we treat them.
Yeah. So if someone's been told they have inflammatory bowel disease, what are some of the symptoms that those people are having?
So you know, one of the most common symptoms are abdominal pain, which you could also see in IBS, and you know, the IBS, IBD, they kind of sound similar, but they're, like she mentioned, is completely different. And the bloody diarrhea, sometimes it can get as bad as fevers and chills, and some night sweats and weight loss. Those are the main symptoms of IBD, whereas IBS, you don't really see the fevers, the chills, or the bloody diarrhea. So that's one of the biggest determining factors. You could also see abdominal distension, nausea, and vomiting, where you most likely will not see that in something like IBS.
Sometimes I have patients that have been told they have IBS, but they've never had any colonoscopy. They haven't had too many tests at all. What would you recommend in that situation?
So they don't need every test under the sun to kind of figure out that they have IBS, but they do need a very thorough history and physical exam. They need to speak with a physician to see how long their symptoms have been going on for, what other symptoms that they have, put it all together, and kind of look for other kind of things that can be going on, and then we'll know if they really have IBS or not.
So if they've kind of ruled out many things and they've determined they have IBS, what are some of the treatment options for that?
Well, IBS can be challenging to treat, but it's a very common condition. About 10% of individuals will end up with a diagnosis of IBS in his or her lifetime. How do we treat? Well, we start with diet. One very common diet that we recommend is a FODMAPs diet, low fermentable food type diet, kind of a strict elimination type diet for 4 weeks, and then slowly adding those food groups back in. There are medications that can also be targeted for constipation or for diarrhea as well. Sometimes there's alternative techniques, improvement with walking, exercise, mental health, all those things. But we focus on dietary changes and sometimes implementing medications as needed to help with diarrhea or constipation.
Sometimes they talk about a connection between our gut and our brain. Could you speak on that? Because sometimes that has to do with IBS too, maybe.
Yeah, absolutely. So we know there's a connection. I mean, it's still being studied. I think at Mayo Clinic they have a whole section that's neurogastroenterology. I mean, that's just really fascinating. So we don't know why, but I do tell my patients it's a real thing. It's not all in your head. Something really is going on. So can certain stressors cause pain? Absolutely. Some people will have chest pain when they're stressed, or an individual will maybe not want to eat. I mean, all sorts of ways that stress and the mind-body connection, it's very real.
Yeah. And on the flip side, then with the IBD, inflammatory bowel disease, we've got Crohn's disease and ulcerative colitis. Could you speak some on Crohn's?
So that's that's one of the subsets. So one of the biggest differences is Crohn's can happen anywhere from the anus down from the anus up to the mouth, whereas differentiated from UC, which is usually just in the colon. Crohn's is a little bit more penetrating disease. It's a little bit more complicated than UC in general. In the sense that it can become a little bit more aggressive. It can be associated with a little bit more extraintestinal manifestations, what we call it, meaning fistulas and joint pains or rashes, which a little bit more than you would see in UC.
And UC, ulcerative colitis, what do patients experience with that?
So the most common symptoms are diarrhea, bloody diarrhea. Crohn's, a little bit more abdominal pain. However, you can see them in both. And less kind of bloody diarrhea in Crohn's.
So if someone's been told they have one of these inflammatory bowel disease, how do we manage that?
Well, there's different types of medications, and it really depends on severity of the disease, from mild, moderate, or severe. So the newer, flashier medicines that are on TV, some of those medicines target very specific parts of our immune system, and they're wonderful medications. Some other medicines for our milder cases are going to be targeting just kind of an anti-inflammatory type, where it's a topical medication that will be treating that part of the GI tract. Patients always ask, is there a role for nutrition in treating inflammatory bowel disease? Well, again, we get back to a healthy, well-balanced diet, avoidance of sugar, processed foods as well. But yeah, there's a wide spectrum of medications for treatment of inflammatory bowel disease.
Excellent. And that's been an exciting field there's things we can do now that we couldn't do years ago.
Absolutely. There's so many choices. It's not like we only have 2 medicines. We have to hold on to those meds for as long as we can because we don't have any other options. Now we're almost tailoring these medications towards individuals, so we can individualize therapy for a patient.
Awesome. GERD, G-E-R-D, which stands for gastroesophageal reflux disease, is a condition where an individual has persistent acid reflux. Dr. Josh Dorn, a family medicine physician at Sanford Health in Sioux Falls, joined Prairie Doc to discuss this disease.
So common symptoms of GERD would be that classic like heartburn. People come in and say, I feel like this burn, this reflux, right? Also, some will wake up in the morning. So some people have what we call silent reflux. They don't have any burning symptom, but they'll wake up in the morning with a bad or acidic taste in their mouth, almost like the taste after you vomit.
Dr. Dorn says diet is a huge factor when it comes to GERD.
So acidic foods tend to be more at risk or more causal of reflux. Tobacco use, nicotine use, coffee, those things will make things worse. Weight has an issue or contributes as well. So people who are overweight or obese are more prone or apt to develop GERD.
Home remedies such as elevating the head of your bed, laying on your left side, along with taking calcium carbonate, can help with symptoms. But sometimes other things are needed.
There are some more advanced procedures that you can do as well if the diagnosis is less clear. And then you can do some, tests to rule out other conditions. But the majority of diagnosis of GERD is just GERD is based on a clinical history and exam.
It is important to record how often you may be dealing with your symptoms.
If you're sick and you're having some reflux, you take it for 2 weeks and then you feel better and you quit taking it and you feel fine. I think it's okay to monitor. But if you're somebody who's, man, I need this every day for a month, it's something that you probably want to go talk with your primary care provider about.
Well, I think most of us have experienced acid reflux at some point in our life, very common thing. But when would you recommend someone get evaluated?
As soon as they feel it, and especially if they're having symptoms more than once a week, then they have typical acid reflux causing enough where it's affecting their daily life. They should definitely seek help for it.
What would be some of the warning signs specifically, or what are they going to be experiencing more often?
So the typical term that we use for reflux is heartburn, which not many, or not everyone knows what that means because it has the term heart, right? But it's a burning sensation. They can have a feeling of a sour taste in the back of their throat. Those are the most common symptoms.
Yeah. If it goes untreated, what can be some of the drawbacks?
So one of the most worrisome drawbacks that we worry about is something called Barrett's esophagus. And that's when you have chronic acid reflux. The esophagus is lined with different tissue than the stomach. The stomach is made to handle acid. The esophagus isn't. And so when you have chronic acid reflux coming up into that area, those cells start to change. They start to become more like the stomach. And that's not their natural kind of area. And so that's what we call Barrett's esophagus. Now, anytime cells start to change from their normal kind of morphology, that becomes a precancerous type of tissue. And Barrett's esophagus in the long term can become a cancer. And so that's what we really worry about. And
unfortunately, esophageal cancer is one of those cancers that can be really tricky to deal with sometimes. What are some ways that we can help treat acid reflux and decrease the risk of that becoming cancerous?
So when we think about non-medication type therapy, elevation of the head of the bed at night, weight loss. Those are the only two proven. So the apple cider vinegars, that's not going to work, etc. So those are the main two. But then it is getting on a medication, typically a proton pump inhibitor, a medicine that will block acid production for an 8-week period of time. And once that 8-week period of time is done, you go back to your physician, you're reevaluated, taken off that medication. If symptoms come back, then it's time to see a gastroenterologist for an endoscopy to look for those warning signs such as Barrett's esophagus. So medication is really a large part of this.
What do you say for some of those people that their symptoms are well controlled on omeprazole or another type of proton pump inhibitor, and they've had a scope and things look good? What would you say to them is like, I just can't get off of this medication? Is it okay if they keep taking it, or what would be some of the drawbacks?
So, I think that if you don't need a medication, don't take it. You shouldn't be taking any medication that you really don't need, right? And so we kind of evaluate, do you really need this medication, right? And you can trial coming off of it and seeing how things go. Now, around 40 to 50% of people will need to come back on something to suppress their acid, unless they do those lifestyle modifications and they lose a lot of weight. But it's not the only option. There's some people that really don't want to be taking a medication their whole entire life, and we know that. And there's other options we can do. So there's structural conditions like hiatal hernias that can predispose you to having acid reflux, where you might get a surgical repair and not need it, and not need another medication again. However, every medication pretty much has risks and benefits. And if you're having chronic acid reflux, then we just go to the lowest effective dose needed to control your symptoms.
Are there any drawbacks to always being on a proton pump inhibitor?
So there is some concerns for long-term use, and it really hasn't been confirmed as what these things are. But there's some concerns for bone health, for kidney health, for Alzheimer's. And again, if I can't say for sure that that's not true. However, the studies are not conclusive for that. So I would say do not kind of focus on that, because we really don't know if that's actually true. And so if you need it, then you need it, kind of thing. And we can treat bone health, we can treat kidney disease, we can look for these things. And so again, yeah, if you don't need it, don't take it. But if you do, then we'll keep that in the back of our mind, that we may monitor your bone health, may suggest a vitamin D supplement, just to kind of keep up with that.
For someone that's interested in not having to be on medication or is having trouble getting under control despite medication, and so if you're thinking about if they should do a surgery like a Nissen or something else, when do you recommend they consider one of those surgeries?
So those would be for our patients who they're on twice a day, you're a maximum dose therapy. There's a whole new brand of class of medications. They've tried the new kid on the block. They're still not doing well. It's affecting their lifestyle, for instance, their throat. They have a hoarse voice, they can't sing in choir anymore. So then we sit and talk about, okay, now it's time to talk about getting you to a surgeon. Again, surgery is a great option. However, for people after 10 years, half of them are back on a proton pump inhibitor. So it's not a be-all, end-all for everyone.
Yeah. Well, the main thing is if you're having issues, go see your doctor and get it evaluated. This person says, I'm in my 50s and was diagnosed with celiac recently. With all the celiac-friendly foods, what are some that I should avoid? What is celiac, and what kind of foods would you recommend?
So celiac, an autoimmune condition where the presence of gluten, which is a protein found in wheat, barley, and rye, damages the lining of our small intestine. So our small intestine, villi, finger-like projections, it looks like a shag carpet. When gluten is encountering these finger-like projections with celiac, it blunts and damages the lining, preventing absorption of nutrients, and in some cases fluids, causing diarrhea, bloat, and nutritional deficiencies. It is actually a very fascinating disease because you don't need a medicine to treat it. You have to just avoid gluten and be very strict about it. So you can avoid wheat, barley, and rye, pizza, pasta, beer, right, all the good things in life. But if you can avoid that and be gluten-free, your disease will become, it'll get under control, and you're going to do great.
I guess they were like, is there any celiac-friendly foods that they should avoid? So I guess if they're going celiac-free or gluten-free, is there something you'd recommend they be careful about? I guess I'm just curious, one way to look at this, sometimes people feel like, if it's gluten-free, it's healthy. And is that necessary? That's necessarily true. So
no, and a lot of the sweeter foods are packaged foods, which are gluten-free, cookies, etc., are really high in, they're processed and high in fat, and so you have to look very carefully at that. So really, you will end up becoming a pretty good cook and making your own things, using almond flour, other ways to learn how to get those sweet foods, because a lot of them are processed. The other thing I would say is oats. I still tell my patients to avoid oats the first year that they're diagnosed with celiac disease as well, because a lot of them are processed in the same mill as wheat, barley, and rye.
And that's going to be a good recommendation for whether someone's trying to go celiac or not, is trying to do less processed foods and less junk food and more whole foods and more natural foods, more fiber. Why are more whole foods, more natural foods better for us than processed foods?
So they contain less artificial ingredients. Really, that's one of the biggest things, and more natural ingredients that have been tried and tested for many thousands of years, and that's pretty much the reason why.
Yeah, I mean, the human body's made for those that we're used to for these centuries. Yeah. We don't necessarily need all these newer chemicals. This person always feels bloated, and my stomach is kind of hard after eating, but does not hurt. What could be causing this to happen each time? Do you want to tackle that one?
I mean, a lot of things. Bloat, I hear about bloat a lot in clinic. So there's common food intolerances, lactose intolerance. Half of us in the United States will struggle with lactose intolerance.
And even as we get older, our risk increases.
Absolutely.
Even though if we didn't used to be lactose intolerant, that can develop.
As we age, and lactose is in everything. I mean, you really have to be very strict about reading labels, but you'll encounter lactose everywhere. Fructose intolerance, that's another huge one we see. Could that individual individual just have a very slow GI tract, and so their gut is not emptying the way it should? Could it be intestinal bacterial overgrowth? I mean, there's a lot of possibilities. So if it is becoming something that's really worrisome to that individual, I would definitely say go talk to your primary care physician about that.
Yeah. There's sometimes people can do breath tests. Mm-hmm. What does that evaluate? How does that help?
So that helps test certain gases that are made from the gut bacteria to kind of see if there's any overgrowth, small intestinal bacterial overgrowth. And if you can digest certain things like lactose. So that's the main uses of these breath tests.
Yeah. I've also, we talk about a person can become lactose intolerant, and just sometimes people in general have more stomach issues as we get older for a variety of reasons. Sometimes patients find they need to make sure they have more fiber to keep their stools moving and regular as we get older, or maybe taking Metamucil every day or something. Why is that? Why do we have to be more mindful of that as we get older?
So the recommended daily amount of fiber in your diet is around 25 to 30 grams a day, which I have probably never met anyone that knows what that means, right? To kind of weigh your fiber is pretty much impossible. And even if you did, it's extremely hard to get that amount of fiber with our diet. And hence the recommendation for taking like a fiber supplement, which helps soften the stool, helps retain water in the stool, and help kind of move things along a lot easier.
Why do you think that sometimes as people get older they have more constipation issues?
So there is a decrease in the motility in general as you get older, and so that's the biggest reason why they have more constipation issues. But of course there's other things in the back of our minds. Are there other things? Do they have hypothyroidism? If it's a new onset change in bowel habit, whereas they recently became constipated, whereas they were going 2 to 3 times a day, and then next month they're going once a week. I mean, that's a little bit more severe, more significant, where we'd be thinking of maybe an obstruction or something else going on. But in general, the gut will slow down as you get older.
And so it can be quite common. When do you get concerned about someone's constipation that's maybe developing?
Well, sure. So I would say, again, going back to kind of our definition of normal, the 3 bowel movements per day to 3 per week, where it's now causing pain or discomfort, that individual is straining, spending a lot of time on the commode, not feeling as though he or she evacuates completely. So then I would say, time to get in, let's talk about that as well. I would also throw in their medications. As we age, we're on a lot of medicines, and sometimes the side effects of those medications can be that one becomes more constipated as well. But yes, if you're starting to really strain, you don't feel as though you're evacuating, there's blood in the stool with evacuation, then it's time to meet up with your primary care provider.
Yeah, good advice. Your gut microbiome is a microscopic world within the world of your larger body. The trillions of microorganisms that live there affect each other and their environment in various ways. They also appear to influence many aspects of your overall health, both within your digestive system and outside of it. Dr. Molday, a professor of nutrition science at South Dakota State University, spoke to Prairie Doc about the gut microbiome and its importance.
And a big part of my research is understanding the role of gut microbiome and the microbes, the trillions of microbes that live in our digestive system and what they do for our health. So by uncovering these connections, we are trying to provide evidence-based insights so that people can live a healthier life.
Dr. Day says that within our bodies, there is a bustling ecosystem full of microbes and much more.
Just think about them as a built-in chemical factory inside our body. They're producing a lot of chemicals all the time, and those chemicals can boost our health if they're beneficial, or if they're harmful, they can contribute to diseases. So taking care, optimizing the microbiome to produce more beneficial compounds, which would then help our many functions in our body so that we generally can stay healthy. That's very important, and it's an ongoing research area.
Food directly affects our microbiome, which depends on it.
So food directly impacts our microbiome, so it feeds the microbiome, right? So they don't have any other source, so they rely on what we eat. For example, if we feed them a high fiber diet, consuming more fruits, vegetables, whole grains, then we actually boost the good bacteria in our gut, and they then produce like beneficial compounds like short chain fatty acids, and these short chain fatty acids have anti-inflammatory role. They are also protective. They protect us from various diseases, whereas there are certain bacteria that can utilize certain components in our red meat, eggs, whole grains, also whole grains, that can then produce like harmful compounds like trimethylamine oxide, which is an atherogenic compound that increases the risk of heart disease.
Day says microbiomes have been evolving with humans forever.
Yes, it's really fascinating the progress we've made and the things we're learning about these microorganisms that are not just bacteria, but viruses and fungi and everything else in our gut, and how it helps us and how it can harm us. And it goes back to the importance of trying to avoid antibiotics. That messes that up unless needed. There's a lot more research to be had, and I don't know if you guys have been involved in any of that research before. Or?
Not with the
You guys are clinic. You guys are just helping people.
Yeah.
But thankfully, we have people like Dr. Day who does that research right here in Brookings. So we've got lots of great questions here. This person asked specifically, what do you think about throat stretching to aid in swallowing? Well, of course, sometimes people can have strictures in their esophagus, and I don't know if that's exactly what they mean. Maybe you know specifically about some throat stretching thing, but
No,
can you
sure.
speak on that?
Throat stretching is a very real and used and helpful modality for people that have trouble swallowing, depending on the reason. We do it all the time. I do it all the time for especially benign strictures where they can get a stretch. There is a role for empirically stretching the esophagus if needed, if someone's having trouble swallowing.
Now, no one's doing this at home on their own, right?
Sure, no.
We're talking about during a scope procedure.
Believe it or not, there is certain instances where it can be done at home, but that's very rare.
Okay.
I wouldn't recommend it for anybody. But yes, this is done endoscopically while most of the time the person's asleep. And we can take care of any strictures or any narrowing of the esophagus to relieve trouble swallowing. That's why it would be done in the first place.
Now, what's that narrowing stricture? What is causing that in the first place?
Most of the time, it's inflammation, uncontrolled inflammation that leads to something called fibrosis.
Like acid reflux, or
like acid reflux. More commonly, we are seeing something called eosinophilic esophagitis, EOE. Which is a type of allergy and or acid reflux, uncontrolled acid reflux, where we might use a lot of throat stretching as well. In very certain conditions, there's some muscular disorders that we would stretch as well. But yes, for the most part, the most common is uncontrolled acid reflux causing what we call a stricture. Yeah.
EOE is a great thing to bring up here, especially when we were talking about acid reflux, because they have similar symptoms, but how do you know the difference between them sometimes?
So, well, biopsies will help us, but it's kind of the history too. If you have a young man who's saying, well, I have a history of some asthma, maybe a little eczema, and whenever I eat turkey, I just feel it gets lodged. And guess what? My dad had the same thing, and my brother does too. So we take that history and we go and we look inside the esophagus, and we can make that diagnosis based on our biopsies and looking underneath the microscope. But yes, there can be overlap. When we see those inflammatory cells like eosinophils, we can see that alone in reflux disease. So sometimes we do have to tease that out. And we treat both with hitting acid reflux hard with the proton pump inhibitors as well. And then eventually some patients with EOE will end up needing stronger medications as a type of topical steroid, sometimes even suppressing part of the immune reaction as well. Elimination diet again, as well as stretching. And there are some patients who respond beautifully to multiple dilations, and they do well for years.
Yeah. There's been someone here that asked from Rapid City, a caller asked, can you touch on liver, gallbladder, and pancreas areas? I guess they're tired of us talking about colon and stomach here. Can you touch on, certainly gallbladder? What are some of the symptoms that someone has with gallbladder disease?
Yeah, so the liver, gallbladder, pancreas is very well integrated into the digestive system. Very, very, very complicated organs, actually. And they all have their role in our health and our disease. Specifically gallbladder, I think one of the most common conditions are gallstones, where typically patients will present with something called biliary colic or upper abdominal pain, most commonly on the right upper. Symptoms that can be leading to a gallstone getting impacted, which we call cholecystitis, is pain after eating. It might go away after a few hours. And if it doesn't, it's more concerning that a stone got lodged or got stuck somewhere in the opening where the gallbladder drains, and it's not coming out. And this is dangerous. This is something that they would need to present to the emergency room for. And there's different areas that gallstones can get stuck. Even past the gallbladder, that might be even more concerning. But that's by far, I think, the most common condition associated with the gallbladder.
Yeah, you have that classic right upper quadrant pain, worse with greasy meals, and
Sure.
take it out so that it doesn't bother you anymore. However, and we don't need it, but sometimes people have issues after gallbladder removal, maybe looser stools, and why is that? And is there anything we can do to help then?
Sure. So the gallbladder collects bile, again, part of this really complex digestive tract that we have. And so when we're eating meals that are higher in fat, that liver is just releasing bile. There's no way to really store and release the perfect amount of bile to help digest that certain amount of fat. And so individuals will have a lot of diarrhea, this bile salt diarrhea. In a perfect world, we wouldn't eat fatty food, right? We would avoid the fast food, fried food, fatty food. However, there are medications that can help bind up that bile and make life a little more tolerable. And usually after 6 months to a year, that should even out for majority of patients.
Wonderful. And then, touching on the liver some, there's certainly many people have found that their liver enzymes were a little elevated, and their doctor's been watching that, and maybe they've been had an ultrasound and it said they had fatty liver disease or hepatic steatosis. Could you speak on that some?
Yeah, so it's actually extremely common these days, and it's more and more common as we look for it, and it's too much fat and carbohydrates that's being consumed by the person who has a fatty liver, and it's so the main cause is dietary kind of lifestyle things that the person has been doing over their lifetime, where now the liver does not know what to do with this excess energy, and is storing it into fat, and it's accumulating around the liver, and it can lead to end-stage liver disease. It can lead to cirrhosis. It's becoming I think it's now the most common cause of liver transplants in the United States. So it's not a benign condition. Right now, the most common treatments for it are dietary changes. Not much other medical treatments are there, but it's something that definitely needs to be watched for. And most of the time, it's actually diagnosed incidentally with imaging. A lot of people who do have fatty liver don't have elevations in their liver enzymes, and so you can say that it's fortunate that people catch it a little bit early, and so they can prevent these long-term changes.
Yeah, excellent. Another reason to get evaluated for your regular visit and to help spot things. A caller has questions about the ulcer drug sucralfate or Carafate. Well, let's go back just one. And what is an ulcer? What are some of the causes?
So inflammation, I would call it like a crater in the lining of the stomach. And so what are the causes? One of the most common causes that we see is due to a bacteria called H. pylori, which half the world has, 40% in the United States, can cause that ulceration. We see it very commonly, though, with medications. Common medicines that you use every day, ibuprofen, aspirin, Aleve, all the NSAIDs can cause this ulceration as well. A peptic ulcer, it can range from something little like an erosion to this deeper cratered inflammatory area that can bleed and cause discomfort for an individual.
And so this medication that sometimes can be used is sucralfate. How is that helping?
That's just kind of a topical protectant. Really, when we biopsy and find these ulcers, we're looking to try to find this H. pylori and treat that. Avoidance of NSAIDs, you can use this kind of cytoprotective medication that will calm that down. But it would be in conjunction with a medication like a proton pump inhibitor, your omeprazole, Prilosec, Prevacid.
Yeah, so antibiotics and the proton pump inhibitors to help get rid of and treat the H. pylori.
Absolutely.
And then help get that ulcer healed up. This 70-year-old male with postprandial distended stomach until flatulation or defecation. I appreciate their words here on the call. Any recommendations? So they get distended stomach, but until they have a bowel movement or until they pass gas.
Sure. I mean,
what could be done to help that person?
So many things. It sounds to me like they can probably have some more or better bowel movements or see some improvement. Sounds like there's some constipation involved here. Where possibly working on their constipation might relieve all their symptoms, including their bloating. That's one of the main routes to go in those cases. Knowing that there are other things that can cause bloating, some dietary changes, definitely one of the most common causes of bloating. But definitely be working on their bowel movements. One of the things that most people will commonly do is to start taking a fiber supplement when they're constipated, right? We tell people that be careful in the beginning because that can worsen your bloating. So kind of gradually introduce it. Don't start taking the full dose from day one, and then say, hey, I feel even more bloated. This is not working. That's a common thing that can happen. So, but for the most part, I think first step is to really take care of the constipation issues, and you might see a huge decrease in their bloating.
And it might be, once again, we went back to lactose intolerance or other causes of gas and bloating, to maybe consider eliminating certain things from your diet or seeing what foods are contributing. But getting to the bottom of constipation would be helpful. And that's along the same lines as this other email. I've been getting constipated since starting a new medication. Miralax helps, but I go several days without a bowel movement. They ask, how often is it normal? And so what do you do for, let's say someone needs to be on a medication and it's causing constipation, but maybe they really need to stay on that medication. What do you recommend there?
One, it's a very simple phone call between me and their physician, whoever prescribed that medication. Is there any alternatives? And if not, and if they really need to be on that, then we can treat it as idiopathic constipation, or it's not from that medication. There are literally probably 20 drugs or 20 medications that you can do for constipation, and some of them are very benign medications like Miralax and fiber, where there's not much, there's really no side effects, doesn't really get absorbed into the body, into the system, just stays in the GI tract, adds more water, adds more fiber, helps things move a lot easier.
Is it okay to always be on Miralax?
Yes, definitely. And one of the things I tell people is don't make that mistake on taking a lot of Miralax all at once, and then in a few days you're having diarrhea, and then you stop taking it because of the diarrhea, and then you get constipated again and you go into these cycles. Miralax is one of those medications where it takes a few days for it to really work, and so you got to give it some time. It's not like some of the more quicker acting medications, but you can really find the right dose for you. You can play around with the dose where you're having a good bowel movement, and it doesn't have to be every day for everybody, but where you're not constipated. Sometimes it'll take maybe 1 cup a day, half a cup a day, 2 cups a day, whatever it is. But if you kind of find that right dose, you should be able to fix that constipation.
Christina, what do you recommend when Miralax isn't doing it either?
Well, I back up to the diet as well. Let's talk about the diet. We can add in nature's laxatives. I mean, we can, your grandmother's prunes. I mean, they work. Yeah. They work for a reason. Pears, peaches, prunes. There was a study last year, 2 kiwi a day helps with constipation, not one, two. But then there are other stronger medications, and so different types that we can target different parts of the colon, drawing in water, blocking some receptors, adding some stimulants as well. We can't be afraid to use stimulant laxatives. I think a lot we kind of don't avoid senna or avoid this. No, it's very safe to try and use those medications. So really kind of individualizing, because there are so many medications that are out there that are available to treat chronic constipation.
And I might throw in there activity and exercise is helpful for the gut. You know, it keeps things moving. Not everyone's able to, and that's part of the reason why sometimes people have more problems with constipation if they're not able to exercise or move like they used to. But just on this program, we also always have to put a plug in for exercise.
And that's one of the overlooked things, but really one of the most beneficial things, not only for things like constipation, but just for their overall health, I would say.
This person, going back to the proton pump inhibitors a little bit, this person from Tyler, Minnesota asks, how long can you be on famotidine, which is a different type of acid reflux medication?
Yeah, an H2 blocker, very safe, really long term. You can use it intermittently, so I would feel very comfortable with that patient using that really long term.
Yeah, excellent. This person says, what are the causes of redundant colon, and what kind of problems does it cause?
So redundant colon is really an endoscopic finding, meaning that someone finds it during a colonoscopy. And for the most part, it's not there for the patient, it's there for whoever's going to be doing their colonoscopy next. Meaning that you might have a little bit of tougher time getting through the colon, but as far as anything else, symptomatically, a redundant colon doesn't really mean much. It doesn't cause any problems.
Their colon is maybe just a little longer.
It just means it's a little bit longer, maybe a little bit more twists and turns. So whoever's doing their colonoscopy, just kind of a heads up that, hey, you might face a lot more turns on this colonoscopy. But as far as things moving through the colon, really does not affect it.
Excellent. Well, in the last 15 seconds, what's our take-home point for today?
I think we didn't touch on alcohol, avoidance of alcohol. That one glass of wine every day, we don't say that anymore. It's associated with multiple GI malignancies, so no alcohol is the best amount of alcohol.
Thank you. Our winner is Jackson. A book will be sent to you shortly. We'll be back after this.
Grab a copy of your local newspaper or read online the Prairie Doc Perspective, a weekly health and medical column. Head to prairiedoc.org to access all archived columns today.
Bringing that up. Thank you to our guests, Dr. Hill Jensen and Dr. Abdu, for volunteering their time to help us learn more about your gastroenterology health. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online, and listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
A hospitalist doctor covers the gap in care from primary care doctor to hospital or from emergency room back to primary care. Hospitalist care, transition and benefits. Next time, On Call with the Prairie Doc.
Hi, my name is Joni Holm, and I serve on the Healing Words Foundation board, the nonprofit that runs the Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you with care and coverage. Hello, possibility. Hello, healthy. Hello, life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,